So welcome to the first episode of Iranian Insight and NMOSD MOGAD case discussion. And we are thrilled actually today to see such a tremendous turnout today. And we have already, I think, 140 registration. And I hope everybody has already joined us. And I think we are set to start at the moment. So firstly, a special thanks to one and only Someira and Jill, Nikki, Michael, and also, of course, Leda from our TSF team, and also not to forget, also a great thank you to Mohammed Ali, Masoud, Hura, and also Samanu from Iranian community for this great contribution to this initiative and this series. So today, as we kick off our series, we are honored to have Someira today with us to maybe give us an introduction to the Someira Foundation first, and then I will briefly go through overview the whole plan and program for this series from now on. And without any ado, Someira, can you please share with us this great journey of 10-year-old Someira Foundation with us, and the platform is yours. Thank you.
Thank you, Sarah, and thank you for being such a great ambassador. Thank you for being such a great partner in illuminating the darkness of NMO and MOGAD around the world, for introducing us to so many great people. Thank you so much for being here. Happy New Year. First of all, I think we're still early enough in the year where we can say that. This is also 10 years of TSF in 2024. So what a pleasure to be starting our 10th year with something that is so needed and something that is clearly so appreciated by everyone in the world, which is bringing all of you together so that we can hopefully help as many patients, caregivers, and even clinician and research as possible around the world. So my name is Someira. I am first and foremost a patient living with double seronegative neuromyelitis optica. I am here in the US. I live in Boston. I'm very happy to be bringing all of you guys together. When I saw the registration numbers, I was totally surprised, but also so excited, because this tells me that we need to keep doing things like this and bridging the gap. And if the foundation can be helpful in doing so, it's my absolute pleasure. So just a very quick history. I got diagnosed in August 2014 when I was 25 years old after losing significant vision and, feeling in many parts of my body, just like how it kind of starts for many other patients. Thankfully, I was diagnosed within 5 weeks of my symptoms, and I was finally given a definitive diagnosis of seronegative neuromyelitis optica in August 2014 here at Mass General Hospital, affiliated with Harvard Medical School. 2 months after I got sick, I decided to start the Someira Foundation to, as the slogan suggests, to illuminate the darkness of NMOSD and MOGAD around the world. I wanted to raise awareness to anyone and everyone who would listen to these diseases. I was very passionate about building communities of support for patients and their caregivers, supporting research and advocating on behalf of patients. I think that this patient voice, especially in rare disease, is really important. So hopefully we've been able to help sort of do that over the years. But now the foundation is 10 years old, as I said. We are global. Our global website is available in 26 languages, Farsi being one of them. So, hopefully enabling people all over the world, no matter what language they speak, understand their diseases or what their loved ones have. So I have a very brief presentation today about the foundation and some of our international work, especially as it concerns Iran. So I will now get started. So we have 4 pillars in the organization: awareness, community, advocacy, and research. We're also very proud to be patient-led, patient-powered, science-driven, and therapy agnostic. I think a very core part of what makes us so different is our diversity. We have a very diverse and robust ambassador program consisting of almost 70 patients, caregivers, and now neuroimmunologists from around the world. As you can see here, everyone looks different. They speak different languages. They're from 24 different countries. But what brings us together? It's the fact that we all have been impacted in some way, shape, or form by NMOSD, MOGAD, and even other rare neuroimmune conditions. Sarah Samadzadeh is one of our ambassadors, so we're very grateful to be working with her. She's been absolutely wonderful in helping us connect with a lot of young physicians around the world, and of course, for bringing this group together for this wonderful program. I think it's important for this audience to know sort of who's behind the organization outside of myself, Michael, who was helping me with tech support, Jill, our chief of staff, who is here, and our ambassadors around the world. We have a very international medical advisory board consisting of some of the top neuroimmunologists from around the world. This committee is led by Dr. Michael Levy, who is our chairman. He's based here in Boston as well, at Mass General Hospital, Mass General Hospital, Harvard Medical School. We have doctors from the United States, KOLs, I should say, Dr. Jefferson Becker from Brazil, Dr. Jose Flores from Mexico. Let's see. Some doctors from France, Germany, Italy, Spain, United Kingdom. Hello, Patty Waters, who is here with us today. Thanks for joining. And then from the MENA region, we have Dr. Sara Salama from Egypt, Dr. Salman Al-Jarala from the Kingdom of Saudi Arabia. Hopefully soon we can see someone from Iran. And from Asia Pacific, we have Dr. Sudarshini Ramanathan and Fabian Brilot from Australia, Dr. Lekha Pandit from India, and Dr. Kazuo Fujihara from Japan. I'm sure these names are very familiar to many of you, but so we're very lucky to call them members of our team. We started funding research back in 2019, and we have funded about 750,000 US dollars in research since 2018, 32 projects funded since 2018 from around the world. We started funding international research in 2022. We also sponsored a special issue in the Frontiers in Neurology focused on MOGAD, which we supported the publication fees of 12 articles from 9 countries. We will be doing the same this year, bleeding into 2025 for the N2 journal. So again, I'm sure a journal that many of you are familiar with, have possibly published in, but they will, you'll see more of that coming out later this year. I do want to take a minute to talk about our global impact. So I am a child of immigrants. My parents immigrated to the US from a very small country called Bangladesh about 40 years ago. And after, a few years into my illness, I oftentimes used to wonder what would happen to me if I had gotten NMO living in Bangladesh, where there actually isn't a single neuroimmunologist. It's even difficult to get rituximab in Bangladesh. And so that's what sort of propelled me and our team to start moving and into the rest of the world, where actually 95% of our patients are. We feel very passionate about bringing the foundation and what we do to other parts of the world, specifically lower middle income countries, because it's so needed. And I think our meeting today is an example of that. So we have legal entities, obviously here in the US, but also in Canada, in Germany, in France, and Italy. We started expanding into the Middle East last year. And actually this year, you'll see some Arabic webinars from some of the KOLs in the GCC region. And then we recently sponsored the Latin American Consensus for Treatment of Neuromyelitis Optica Spectrum Disorder in collaboration with LACTRIMS. This is a milestone for Latin America because until now they did not have guidelines for NMOSD treatment. So now that we have these approved therapies, we're working on this with many of the key opinion leaders in Latin America. And of course, our global diagnostics initiative, something we're very passionate about. How do we help folks get diagnosed efficiently and accurately in parts of the world where it's very challenging? And part of that initiative is our short-term fellowships. In fact, our very first short-term fellow was Dr. Zila Maghbouli from Tehran University of Medical Sciences at the Sina Hospital. She spent about
نکن چیکار کردی؟
She spent about 1 month with Patty Waters at the University of Oxford. Thank you, Patty, for hosting her, for mentoring her. And the idea is that she will go back to, that she went back to Iran to help sort of make diagnosing more efficient and accurate in Iran. And of course, we have this meeting, which I'm very, very happy to facilitate. And now I will stop my presentation. And Sara, we go back to you.
Yeah. Thank you so much. Great talk as always. And it's always inspiring to hear about the extensive community and also impactful work of TSF. And now I'll be sharing my slides. I have just one actually, but I need to have like access. I think you need to allow me to share my slide. Oh no. Okay, so this is our logo for now. So the idea for the Iranian Insights and MOSD MOGAD like case discussion and lecture series stemmed or came to us from a desire actually to network and can communicate, connect with other experts from all over the world, from Iranian inside of the country and to Iranian outside of the country, and also with other experts in the field. And our format, a little bit about our, our series format. Our format will alternate monthly from case discussion to a lecture, and then we will try to have like a specific session to recap and also have like a highlights on different NMOSD MOGAD meetings through the year from now on. And we also plan a segment maybe for an informal talk with scientists and early career researchers worldwide about their journeys and also their projects, and then again trying to foster more connection and more communication between us here in Europe and also in US and also Iranian inside of the country. We'll be, as Someira actually mentioned before, we'll be recording these sessions for our YouTube channel, TCF channel, and also possibly we will try to create like a specific content for our initiative, our series as well. And if you have suggestions or ideas for to implement in our series, we are open to have your suggestion, and please reach out. Feel free to reach out, and we will try to keep it like really innovative and to connect to be like a bridge. At the moment, we also, as I invited a couple of my colleagues from other regions, we are exploring also to have joint session with other regions, including maybe an upcoming one with the Balkan area, with Montenegro, with Turkey, and also maybe afterwards with other Middle Eastern countries as well. So these are the whole aims and like objectives of our series at the moment, but we will grow and we will evolve from now on, and we will try to have more creative content. So this is our agenda, and as Someira also, we had like a nice, great talk from Someira, and that was like just an introduction to the series. We will have, of course, case presentation, case discussion, and at the end, closing remarks for our today case. So I will stop my. So now, thank you, and also now let's proceed to the case presentation by Samana. Please introduce yourself at first for us, for who don't know you, and start a case. Please, the Zoom platform is yours, Samana. I think I can share your screen now.
I can't share my screen.
Try it again, because I just changed from one participant to multiple participants can share simultaneously, so you can share it. Perfect, yes, I think. Great, yeah.
Taking our respect to Professor and colleagues, I'm Dr. Samane Kadri, Fellowship Assistant at Tehran University. Today, I'm introducing a patient who was referred to Sina Hospital. I requested the respected professors to guide us about the treatment methods. A 23-year-old man who was known case of the mild mental retardation was admitted to our neurology department for quadriparity and urinary and fecal incontinency from 4 weeks ago. Symptoms started with urinary retention and paraparesis that is followed days later by upper and the fecal incontinence. His family described a nuanced behavior changes like aggression and non-specific blurred vision in the last 2 months. Because patients can't describe well, we don't know the details. He got 5 days.
I'm so sorry. Oh. Hi, guys. Samana is on mute. But we do need everyone else to.
Can you hear me?
Yes.
Yeah. Yes, I think I can mute all, and then you can also then again unmute yourself. Samana, could you please unmute yourself, because I tried to mute all of others.
Can you hear me? Yes.
Yes.
Yes, he got 5 days course of methylprednisolone about a week after the symptom onset. That was not helpful, and no improvement was happened. Then plasmapheresis was done for 7 sessions without any improvement. At this time, patient referred to Sina Hospital. He didn't have history of any recent infections. He didn't use any drug. In physical examination, he's a mild mental retard, but he understands what I say and obey them. Fundoscopy is normal, no evidence of disc swelling and hemorrhage. Both upper and lower extremities forces is about 1/5 with spasticity. Plantar reflexes are off at both sides. Now we see the initial MRI at the primary center before the treatment initiation. The brain MRI shows bilateral, ill-defined, multiple hyperintensity lesions. T2 hyperintensity lesion in the midbrain and pons, and T2 hyperintensity lesion in the right thalamus. And also here. And lack of T1 black hole or T1 hyperintensity is present here. In a spinal MRI, shows patchy lesion extended from upper cervical to conus with gray matter predominant involvement that shows H sign with minimal enhancement. After patient referred to our hospital, about 1 month after first MRI was done for him again. In a repeated MRI, some lesion is resolved and without any enhancement. In cervical and dorsal MRI are also resolved the lesion and disappear. In evaluation, MOG antibody is positive 130 seconds. He received 125 gram IVIG over 5 days and 50 milligram oral prednisolone every day. After 3 weeks, he able to walk with help, but visual sphincteric dysfunction is present. Now finish the patient history, and I request the professors to guide us about the clinic and treatment.
Thank you so much for great presentation. Thank you. So now I invite Masoud, Mohammad Ali, and also to firstly introduce themselves for those who don't know them, and then Masoud to proceed with a case discussion. And we have like today's guests, Meral, Rabia, Kabir, Sanya, and also our honorary guest, Paddy, to jump in and ask questions, comments, and insight for the case discussion part. Thank you. Please, Masoud and Mohammad Ali.
Hello, everyone. My name is Masoud Majid. It's a great honor for me to just be here working with you. I had a pleasure to be a student of Dr. Zahraian. It's amazing for me to just be able to work with her. So I went to med school in Iran, in Tehran University, more than 2 decades ago. And about 10, 15 years ago, I came to US basically to do research and clinical practice. I did a research fellowship and a neuroimmunology fellowship at Mayo Clinic in autoimmune neurology, where I fell in love in NMO and MOG and vast other autoimmune neurology diseases. I did another fellowship in WashU, and I recently joined USC as a faculty. Very good. So I can go through my slides.
Recording,
So these, you see my slide?
Yes, I can see your slide.
Screen recording.
Could you please maybe mute yourself? Sajjad?
Okay, so I'm going to go through the clinical presentation and diagnosis first.
Yes,
and I will go. Then finally, I will talk about my.
Just 1 minute.
Dr. Sajjad, could you please mute yourself? Okay.
And then at the end, I will talk about my suggestions for further management. And it would be great if I could hear others' opinion about my suggestions for further management. So for me, the main point about the initial presentation and imaging finding is that they're very, very highly indicative of MOGAD, and they give us a very high pretest probability for MOGAD. So his initial presentation simply was mild encephalopathy followed by a severe myelopathy. And in MOGAD, the myelopathy usually presents at younger age compared to NMO patients. A retrospective study showed that the average age of patients presenting with myelopathy in MOGAD is 33 years old, which is more than a decade younger than what you see in NMO. They can have all the symptoms you expect in myelopathy, but more dominant motor and bowel bladder symptoms, and it's usually very severe at its nadir. Patients are usually paraplegic or quadriplegic at its most severity, and they have significant bladder dysfunction. The other unique finding in MOGAD is that in about 10% of them could have ADEM-like presentation associated with myelopathy, which is very uncommon in other inflammatory myelopathies. Actually, the initial DEVIC syndrome presentations, the one that we call DEVIC, and then their NMO, They were not AQP4 positive, and since they were actually MOG positive patients, the one who had simultaneous transient myelitis and encephalopathy and optic neuritis. So similarly, in our patient, see that he's a young man with very severe myelopathy and associated with ADM-like presentation. So clinically, it is suggestive of MOG. Going to neuroimaging, I'm going from top to the bottom. Neuroimaging is even more suggestive of MOG. In brain MRI in the supratentorial area in MOG, you would expect to see multiple fluffy, poorly defined T2 hyperintense lesions in the white matter. And you might see lesions in the gray matter and some leptomeningeal enhancement, which this patient doesn't have, but he clearly has those classic fluffy lesions that you see in the periventricular area and the white matter in supratentorial area. Going down, you would see this lesion in the right thalamus, which is commonly seen in MOGAD, especially in children and young adults, but you don't see these type of lesions in NMO or other demyelinating diseases. The type of lesions you see in NMO and AQP4 positive NMO is usually in the midline, kind of different from the lesion you see here. Going further down to the brainstem, you have lesions in midbrain pons and medulla in MOGAD, and the very common thing in MOGAD patients is that it commonly affects corticospinal tract. It can be in the level of internal capsule, or it can affect the peduncles in the midbrain. And very similar to this lesion that you see in this patient, it's in the peduncle, and also affects the corticospinal tract in pons. That's commonly seen in MOGAD. Another location that's commonly affected in MOGAD in brainstem is MCP, middle cerebellar peduncle. I didn't see it get affected in this patient, but the midbrain lesion and pons is suggestive of MOG. The spine MRI, you would expect in MOGAD, you would expect to see long, extensive T2 hyperintense lesions. And in the sagittal view, they commonly make this ventral sagittal line, a line in the anterior part of the spinal cord, very similar to the line that you see in our patient in the first image that is here. That's exactly the ventral sagittal line, and in the axial view, as Dr. Kabiri said, you see it's predominantly affecting gray matter, causing this H sign, which you see in this patient. Another thing that is completely different compared to NMO and other differential diagnoses such as sarcoid or lymphoma is that the enhancement is very, very minimal in MOG, and that's quite telling. As you see here, there's in the image at the right, see there's very minimal enhancement, but compared to the length of the lesion, it's really, really small, which is what you see in MOG. Going further down to the thoracolumbar spine, we see this lesion in the conus, which you don't see in NMO, in AQP4 positive NMO, we don't see these lesions. This is highly suggestive of MOGAD, and the other finding is that you see multiple lesions. There are multiple long extensive lesions, which commonly seen in MOG, and again, you see the H sign in the conus lesion as well. So overall, the clinically and imaging-wise, we have very, very high pretest probability for MOG. The imaging that was done 4 weeks after the initial presentation at Siena Hospital, I see the first MRI and the second MRI. When you compare the images, you see that some of the lesions, it seems they're resolving. For example, if you get this periventricular lesion at the top, you see it at the bottom, it's very, very small. Same as the thalamic lesion and the midbrain and the pons lesion. It seems they're going through the resolution. And the more interesting thing is that you don't see T1 hyperintensity when you look at the MRI. Similar findings you could see in the LETM lesions. In the lesion in the spinal cord, you see a dramatic change just after 4 weeks. The T2 hyperintensity is resolving, both in the cervical and the thoracic spinal cord. And, that's exactly what you expect from MOG. Multiple people have shown that the lesions resolve completely in up to 80% of patients after about 3 months, and in our patients after a month, they're going through resolution. And they usually don't cause T1 hyperintensity. Overall, it seems that if you do the MRI late in MOGAD, you might not see any evidence of the lesions, completely in contrast to NMO and MS. Of course, in MS, you have your T2 lesions that are there for a long time, and it has T1 hyperintensity. In NMO, the T2 hyperintensity might go away, but patients usually have big lesions in the T1. You see big black holes in the T1 MRI, but in MOGAD, T2 lesions go away and there is no T1 hyperintensity, and that is the common finding that we see in MOG. So overall, as I said, clinically imaging-wise, highly suggestive of MOG. In CSF, the basic studies usually show some flow cytosis and oligoclonal band is negative. I understand the CSF analysis is not done for our patient. Is that correct, Dr. Kabiri?
Simon, are you there?
Yes. We didn't perform the CSF analysis, and we don't have any data from them.
Okay, very good. Okay, so clinically, we have high pretest probability for MOG, so it's very reasonable to do a MOG assay for these patients. Of course, when you have Dr. Waters, I don't need to talk about the assays, but just going over this type of assays that we have, the optimal assay is the live CBA using full-length human MOG, which everyone started to use after Dr. Waters published an article in 2015. So there are two ways to do the live CBA flow cytometry assay, or looking at the cells under the microscope. At Mayo Clinic, you use FACS assay, where you see quantitative fluorescent ratio between MOG transfected and non-transfected cells. Then you have this binding index. If the binding index is above 2.5, you can call it positive MOG, or you can look at it under microscope compared to transfected cells with non-transfected cells and call the positive cell. A slightly lower specificity is seen when CBA is done with fixed cells, and the reason that you have lower specificity with fixed cells is that will you lose your spatial configuration of the MOG and the membrane, and of course you losing the conformation of your epitopes, and you would lose your specificity. And of course, a much lower specificity is seen in the test that we were doing 2 or 3 decades ago with ELISA and Western blot, and they are not really that good to identify MOG or GG. So the question is, if a patient comes to clinic and they're positive for MOG, does it mean they have MOGAD or not? I mean, what is the positive predictive value of MOG? Which means the patient comes with a positive test, what's the likelihood of having MOGAD? It's not 100%. A study was done at Mayo Clinic looking at live cell-based assays and measuring the positive predictive value. It's highly dependent on pretest probability and the titer. For a patient like ours, which has a very high pretest probability, the positive predictive value is very high, more than 80%, which means from every 10 patients, more than 8 of them do have a MOGAD and they have a positive test. Also, titer matters. If the titer is very high, the diagnosis is definite. If titer goes down, the likelihood of a MOGAD decreases. And of course, no one has, as far as I know, no one has done this type of study for ELISA or Western blot, but I'm sure it would be much lower. The numbers would be much lower for ELISA and Western blot. And I understand our patient had an ELISA assay, just as Dr. Kabiri before our presentation, which makes it a problem for the diagnosis. My other question is, Dr. Kabiri, was the test done before or after steroid?
The sample was taken in the first center before the patient referred to our hospital. So we don't know the sample was given before the immunotherapy or not. We don't know this data. And I think that because unfortunately we don't have a live cell-based assay method in Iran. Most probably it's done by ELISA.
Nice.
So the reason I ask about immunotherapy, we have evidence that immunotherapy, especially steroid, can cause seroconversion in patients. So that would be a problem of course, assay. So overall, going through what I talk about now, the clinical imaging shows us very, very high pretest probability for MOG. If this patient was tested positive with a live CBA with high titer, there would be no question, it would be definite MOG. If it was tested positive in CBA with low titer, I would say it's most likely MOG, but I would like to go through differential diagnosis. If it is positive in an ELISA, such as what we have here, it's probably still probable MOG, because of what we see clinically and imaging-wise, but I would make sure I would rule out the differential diagnosis that we have. And, for me, the differential diagnosis of an inflammatory myelopathy, I say inflammatory because it's subacute onset and responded to immunotherapy. As inflammatory myelopathy with gray matter dominance and long extensive lesion associated with brainstem lesions, the differential diagnosis is MOG, AQP4 positive NMO, sarcoidosis, and lymphoma. Actually, I had a patient, a 20-year-old male that came with lesions very similar to what we had here, very long extensive lesion in the spinal cord, H-sign lesions, went to the CONUS. I was kind of sure it would be MOG. Actually, MOG was negative, and cytology showed lymphoma. We did a PET, and all the lesions lighted up. So it was actually a lymphoma. So for patients like this that we have an ELISA assay, I usually want to have AQP4 IgG assay, a CSF cytology, and a CT chest, abdomen, pelvis. If you could have PET for both lymphoma and sarcoid, that's even better. But if not, those tests, I think would be enough. And if those tests are negative, then I would feel comfortable calling it MOGAD, even with an ELISA assay. So this is about the diagnosis. I just wanted to go through the criteria that was published last year. For the criteria of the MOGAD, you need to have core clinical features. A patient has at least 4 of them. And then you want to have a positive...
Sorry to interrupt you. We have like one question. Can we proceed with question in between? Sorry, Nasir. Meryl.
Hi. Very nice presentation and case. We are living in Turkey and Iran also. I know that Behçet disease is also another differential diagnosis. Do you think for this case to make differential diagnosis of Behçet disease also?
Very, very good questions. Yeah, absolutely. Behçet would be highly in my differential. I mean, probably I've seen more Behçets than me, but the lesions I've seen in Behçet, they usually don't go to CONUS. And I expect to have much more enhancement, but definitely it is in the differential. If it wasn't going that down, and if the lesion was more like cascade lesion, it was a lesion in the thalamus, there was a small lesion in the midbrain, but it didn't look like the classic cascade lesion that you would see. Also, because it was going really down to the CONUS, I still haven't seen a Behçet patients going that down. If you have, let me know. But yeah, of course, if the lesion was not going down, I think the other diagnosis for me would be Behçet as well.
Thank you very much. We should keep in mind the Behçet disease in this area. Thank you.
Yeah, of course. Yeah, we do see, actually, I've seen a couple of Behçet patients with LATM that were actually coming to us for possible MOGAD, and they ended up being Behçet. Exactly, yeah. It's definitely differential, but again, usually the lesion doesn't go that down. And it usually has, at least in the spinal cord, has some white matter lesions. It's not just in the gray matter, the myelopathy of Behçet. Very good, great question. Yes, of course, it could be in the differential if the imaging was a little bit different. So going through the criteria for this patient, of course, as I said, it has the core features, at least 4 of them, and the MOG IgG is positive. If it's low positive, you want to have a negative AQP4 IgG and at least 1 supporting feature. Our patient has all the supporting features that you could see in the criteria. So it has all of them. And based on the criteria, you can diagnose it with MOGAD. The problem is that this criteria was for cell-based assay. If you have an ELISA, we cannot use this criteria. And we're gonna rule out all the other differential diagnoses before call it MOGAD. Okay. So moving from diagnosis to treatment, we know that MOGAD is very steroid responsive, and the sooner it's started, the better the outcome is. We usually do artesunate or equivalent of oral prednisone for 5 days. Understand our patient was started on steroid and didn't show that much benefit to the steroid. I'm not sure if it was started early on, but regardless, the patient didn't show that much response. In these situations, most people, even if the attack is severe, even before you see the response to the steroid, experts suggest to start flex with the steroid at the same time and do 7 sessions. Since our patients started on flex after the steroid, but still didn't respond. So my question was the plex was how many plex sessions was done? Was it 5 sessions, Dr. Kabiri? And
no, 7 session is done, and about 12 days after the symptoms onset, plasmapheresis is started, and 7 sessions is done.
Got 7 sessions of plex, 5 days of steroid. Gotcha. Very good. Because it seems after it came to Siena Hospital, a prednisone taper was started. Of course, it's a great treatment when the patients don't respond to steroid and plex. The steroid oral prednisone taper helps twofold. One is it helps with the treatment of the acute attack with the residual deficits, and also it helps preventing early relapses. So I understand our patient was started on prednisone. Sorry, Dr. Kabir, can you tell me the dose of the steroid that he is on, and do you have any plan?
Patient receives 5 gram phosphomethyl prednisolone, and after that, he receives 50 milligram oral prednisolone every day, and we plan to decrease dose of 5 milligram per week every week for him.
Okay, so you're going down 5 mg per day, after that 50 milligram batch every week. Very good. So, and the other treatment that we commonly use when patients don't respond to the other treatments is high-dose IVIG. And by high dose, I mean 2 gram per kg. So I understand our patient received 125 gram of IVIG, and I assume it was 2 gram per kg. Is that correct?
Patient's weight is about 60 kilos, and we done.
Perfect, very good. And that's usually the treatments that we commonly use here as well. High-dose steroid, plasmapheresis, steroid taper, and IVIG. There's some other treatments that are suggested, but there's very limited evidence for them. People use interleukin-6 targeting treatment for acute attack treatments. They use tocilizumab, sertolizumab, and also some people have suggested using eculizumab in acute attacks, because there are pathology slides, do you see some MAC complements in the tissues in the biopsy, but we don't know how essential is the complement cell cytotoxicity in MOG, and there's not too much evidence that eculizumab helped in the acute attack. And I myself usually just use them when the patient's very, very severe, they're in the IC and they don't respond to other treatments. I've used tocilizumab in these situations, and it has helped with the acute attack treatment for those patients. So this is what has happened so far to the patient. And before I jump to my suggestions for further management, I just want to talk about 2 things. One is the prognosis of LATM in MOG, and the other one is the risk of relapse in patients with MOG. So as we know, unfortunately, the prognosis of LATM in MOG is really good, especially for motor symptoms. Patients might be wheelchair bound when they come to us, but at the recovery, their EDSS averages between 1 or 2. Unless they have a lesion in brainstem. We've seen patients who have lesions in brainstem, the corticospinal tract, actually do a little bit worse. Their recovery EDSS is somewhere between 3 to 4. They still are able to walk for short distances without any aid, but might need a cane or something for longer distances. The situation with bladder dysfunction is different. We do see persistent bladder dysfunction in up to 50% of patients who present with bladder dysfunction, especially those who have Conn's lesions like our patient. So for our patient, I would expect to have a good chance of having persistent bladder dysfunction, but I would expect his motor symptoms to recover really, really good. And at recovery, my expectations for him to be able to walk without any aid for at least short distances. As far as I know, based on what Dr. Kabiri told us, he's able to walk with help so far and has had no improvement in incontinence. So my question is, how long has it been since symptom onset, since the first day that he presented, and where are we now with his motor dysfunction and bladder dysfunction?
Now the forces is about 3 feet, and he can walk with urinary third aid, and the EDSS is about 6, and the spine-case dysfunction is present without any improvement, and he urinary and fecal incontinence.
Oh, okay. And how long has it been since onset? 2 months, I guess.
2 months, yes. Now 2 months.
Okay. Okay. So, based on what we expect from LATM in MOG, I would expect him to recover even more. And because we're still 2 weeks after the onset, I think there's still room for more treatment. Okay, so I will talk about it at the end. Thank you very much. And so before I jump to those suggestions, let me just talk a little bit about the risk of relapse. As you know, relapsing course is seen in approximately 50% of patients, especially those who have persistent seropositivity, or at least they have a lack of decrease in their titer. And of course, in these patients, because of the risk of relapse, we start attack preventive treatments. Experts suggest to start attack preventive treatments in another group, which are the patients who have severe residual disability after initial attack, even if they don't have relapse, and even if they don't have evidence of persistent seropositivity, just because you don't want to have accumulation of disability. So our patient at least fits in the third category, and I would consider starting maintenance treatment for him, even if there's no relapses. So the choices that we have, we still don't have any published or done clinical trials for MOG. So most of our data is based on retrospective studies. But almost all the big studies that have done across different centers shows that IVIG is probably the best treatment that we have. It has been shown to be better than rituximab and azathioprine and mycophenolate for prevention of the attacks. And the higher the dose, the lower the risk of relapses. So the high dose would be 2 grams per kg every 4 weeks. After that, we have azathioprine and mycophenolate, which did not as good as IVIG, but still actually they did better than rituximab. And the third option would be Ritux. It does better if it started as first line, but still it seems that mycophenolate and azathioprine are better in preventing attacks compared to rituximab. An exciting thing is that we have 2 clinical trials on MOG right now. One is ancestralizumab, which is interleukin-6 targeting treatments. So it's based on what we see in patients who are treated with tocilizumab. It seems it's really good in treating severe attacks and preventing flares. And also we have seen really high interleukin-6 in the CSF during the attacks. And the suggested pathogenesis of MOG is, it seems that there are pathways that interleukin-6 affects them. So sertralizumab is one trial, and another one is rozanolixizumab, which is an anti-neonatal Fc receptor. It basically works on modulation of the antibody and recycling of the antibody on the surface. This is another exciting clinical trial that is currently underway, and they're both at the level of recruiting patients. So we don't have the results yet, and so far the options that we have for maintenance treatment is IVIG, azathioprine, CellCept, and rituximab. So based on all of this, these are my suggestions for further management. We'll go for my suggestions in 3 sections. One is diagnosis. In terms of the diagnosis, if it is possible, I would repeat the assay right now with a cell-based assay, if it's possible. And the reason I would do that is that if the cell-based assay becomes positive, it confirms the diagnosis. If it's negative, it doesn't help because it's after immunotherapy. In addition, doing a cell-based assay right now will give us a good titer, and if we monitor the titer in following months, it can help us with assessment of risk of relapse. So if it is possible, I would do the cell-based assay, live cell-based assay in MOG-IgG now. I will make sure I rule out the differential diagnosis. I would for sure check AQP for IgG. I would check for cytology, and I would do CT chest, abdomen, pelvis. If I can do PETs, that would be even better. And the last thing is that I would do some investigation into the mild intellectual disability that our patient has, especially with the significant ventriculomegaly that I saw in the MRI. There could be some underlying genetic disease, that increases the risk of autoimmunity in this patient. I cannot think of any specific disease based on the MRIs that I see, but I think it's worth investigating that. So these are my suggestions for diagnosis. In terms of the treatment, Because we're still in, for me, it's in the acute phase, it's just 2 months, and I think he hasn't had the extent of recovery I expect to see from LETM in MOG. I think there's still room for more aggressive immunotherapy. I think there's still room for steroid and plasmapheresis. Of course, I would continue the steroid taper, and I would taper it very slowly over 3 months. And again, I would continue IVIG at the high dose, 2 grams per kg every 4 weeks. So the way I would do it is that I probably would admit the patient now. I would give him high dose steroid, 1 gram daily. And at the same time, I would do Plex for 5 sessions, day 1, 2, 4, 6, 8. And then right after the last Plex and last dose of steroid, I would restart IVIG, of course, because Plex gets rid of the effect of IVIG. Just after I finish with plasmapheresis, I would give another loading dose of IVIG, and I would start prednisone taper very slowly. I would start at 60 milligram per day, and I would taper it slowly over 3 months, hoping that I get more basic recovery. And, my goal for his motor symptom would be to walk independently, at least with no aid, at least for short distances. And the last suggestion I have is for monitoring disease activity. The first thing I would do is I would do a baseline OCT. For all MOG patients, I do a baseline OCT, even if they don't have optic neuritis. The reason is twofold. You could see if there's any subclinical evidence of MOGAD in OCT, if there's thinning of RNFL. That helps. The other thing is basically we'd have a baseline for possible future optic neuritis. You can compare, if patient comes with symptoms of optic neuritis, you can compare the OCT done during the attack with the baseline OCT. I would also repeat the MRI brain and spinal cord 3 to 6 months from onset, and I would expect most of the lesions to be completely gone. If the patient recovers really good, as we expect, I would do the MRI maybe around 6 months. If it doesn't recover as good, I would do the MRI sooner, maybe around 3 months, to see if there is any new disease activity. And the last thing is that I would check the titer of the antibody 6 months after the onset to see if there's any increase in the titer. If that is the case, then it means the patient is at risk of relapse and maybe is undertreated in that scenario. So yeah, that's all I have for the patient. I would really love to hear others' opinion, and yeah, that's it.
Thank you so much, Masoud. I think we have one question from Rabia. Please, Rabia.
Hi, everyone. Thank you very much your presentation and absolutely good discussion. I want to ask a question. In the history of the patient, he had got blurred vision for 2 months. And maybe he had got an optic neuritis attack. Maybe we can do OCT, web, visual wave potential, or orbital MRI, and we can see a lesion in this methods, and these findings may be supportive for the clinical and radiologic diagnosis in MOGAD. Thank you very much. This is a good educational case.
No, of course, I completely agree with you. That presentation could be because of that. But it seems, when they did fundoscopy, there was nothing during the vision was good. To my experience, for the optic neuritis of MOG patients that I've seen, almost all of them had significant disc edema at the initial presentation. And I think the optic MRI was done. There was nothing. That was if it's not done, yeah, I agree with you. It should be done. But maybe if we do it now, we might not see the lesion in the MRI now because it's been 2 months from the onset. I agree with that. I think OCT would help that. I think OCT is more sensitive than VEP for MOGAD because the lesions of the optic neuritis in MOGAD are very anterior, really long anterior, and lots of edema. Almost all of them, at least in the acute phase, you see a lot of edema in RNFL. The thickness of RNFL can go to 180 micro, basically, in the acute phases. And then you would see thinning of the RNFL. So I think that's more sensitive. And, the vision symptoms could be contributed to some of the brainstem lesions, but I agree with you. Optic neuritis could be, or subclinical, I mean, yeah, undiagnosed optic neuritis could be there. I think at this stage, OCT will help more. If MRI of the optic nerve is not done, I agree with you that that could also help for sure.
Thanks again. Sania, please.
Thank you, Sarah. Thank you very much for this really illustrative case. It's more just like a comment. I'm from Montenegro. We do not have a lot of MOGAD patients, but we do have a similar case like this one. And our patient had as well urinary retention and paraparesis after the first attack. And we continued high dose oral steroids. He was 80 milligrams. Not even 60, and we put him on IVIG for the next 6 months monthly, and he still had no response. But I do, from my personal point of view, I do believe that in these patients, high steroid treatment and IVIG are the best follow-up treatments, and I agree absolutely with you that these patients should be left on chronic maintenance treatment due to severe, just like all NMOSD and MOGA, they do share the same thing, that they can leave a permanent damage, unfortunately, for our patients.
Yeah, very good. Thank you for sharing that. No, exactly. It's sometimes, if the patient doesn't respond to steroid and IVIG, I doubt if it's MOG. I usually investigate more and more if I don't see response. I want to see something. I had a patient with sarcoid that was really like this patient. It was edge sign, big lesions. Again, I have had 2 young males with B-cell lymphoma that exactly presented like this. So, there are differential diagnoses. If MOG is negative and doesn't respond, I would dig into it to see what it is. As you know, at least the motor symptoms, almost all patients recover really, really good. I've had a few cases of MOG that they didn't respond that good, but it's very rare that they don't respond.
Yeah, I agree. Thank you. Thank you very much.
Thank you. Please, Patrick.
Great. Thanks. It's a great presentation. I just wanted to comment or question a little bit about the last point. So in the early publications on MOGAD, the most residual disability was from the onset attack. So can you differentiate? You were saying you doubt if it's MOGAD if the disability doesn't recover. Can you have people who have long-term disability in some area, but they also have resolving lesions?
Thank you for that presentation. Yeah, I think we definitely can. The lesions, it seems, in most patients resolve, but many of them do have some residual deficits. I think the ADEM patients, when they were followed very long, even after one attack, I think they had some cognitive issues. Again, LATM patients had significant bladder dysfunction, but correct me, but in the LATM patients, if they come with significant motor symptoms and the motor symptoms don't recover, I think that's kind of unusual for MOG. I would expect the motor symptoms at least to recover near completely, maybe not complete, but I would expect clinically their motor symptoms to go near normal, at least after the initial attack.
Great, thank you.
So we also have like 2 questions in a chat. So firstly from Samira, that how long will we continue IVIG 2 gram per kilogram AKG?
Question. I don't have a very good answer to that, but I'll tell you what I do usually. So unfortunately, we don't have definite marker that can predict disease attacks. Of course, the titer of the antibody helps. If the patient becomes seronegative, I might consider going down on the dose of the IVIG. If the patient completely recovers and the titer goes down, those are the 2 things that I use basically to modify the dose of the IVIG. I'll tell you what I've done for my patients, but I don't have robust evidence for that. If for patients who completely recover and the titer goes down and becomes seronegative, After a year, I will go down on the dose of the IVIG gradually and see how patients do. If there's any sign of the symptoms coming back or a flare, I would go back and I don't stop it. But yeah, I start usually at 2 grams per kg. After a year, I go to lower doses, gradually to 1 gram per kg every month and see what happens. But, it's a good question. Since I don't have the answer, how long should we continue the treatment for these patients? I think it's a problem for all autoimmune diseases. For NMO, you start eculizumab, how long are you going to do it? Yeah, I don't know.
Thank you. And also there is another question. Isn't it the possibility that PLEX nullify the effect of IVIG?
Absolutely, definitely, for sure. And that's why I said, I would do steroid and PLEX, and right after the last session of PLEX, I would start IVIG exactly for that reason. All the effects of the IVIG that you have, PLEX gets rid of them, but I think we still have room for aggressive treatment, and that's why I would do, PLEX helps in the severe cases and high-dose steroid, so I would do that, and then right after the last session of PLEX, I would do the IVIG, regardless of how many days ago the last dose of IVIG was. I completely agree. So I would like to know Dr. Sahrayan and Dr. Waters' opinion about the treatment.
Yes.
What for treatment for this patient?
Thank you very much. Thank you very much, Masood, for your nice presentation and explanation about the patient. Before my response, I would very much like to thank Sumaira and the foundation for organizing this session, and also I'm so thankful to Sarah for managing all the equipments and sessions to have this wonderful meeting, and you, Masood, for accepting our invitation to get this nice presentation. Actually, we plan to manage this patient with IVIG monthly, as you said, but the problem is that IVIG monthly will not be covered by government for a long time. And IVIG is so expensive if the patient wants to buy out of his pocket. So we decided to also combine one immunotherapy, which is we started azathioprine for this patient with IVIG. And our plan is to continue IVIG for 6 months. And then we will continue only azathioprine and steroid and azathioprine. At the moment, the patient is receiving actually azathioprine, prednisolone, and IVIG. As far as the patient recovered, I will stop, I think, IVIG, and I will continue with azathioprine and a low dose steroid. And at the end of 6 months, I will also stop a steroid as well. So this is our plan for this case, and we have started this case. The problem with tocilizumab is that at the moment it's not covered by the government for the MOGAD, and the patient cannot buy it independently without insurance. So we are planning to persuade the government to pay for this patient at least for 6 months IVIG, and then we will stop. If I had actually the facility to continue IVIG, I had the plan to continue it at least for 1 year monthly, or at least when the patient has no residual disability in walking. So this was my plan. So we continued this patient with actually combination therapy of azathioprine, steroid, and IVIG.
Thank you.
Thank you so much. I would like to also thank you, Professor Sahrayan, for this great contribution to the series, and also could you please introduce yourself for all who do not know you from other parts of the other regions? Thank you.
Okay, my name is Muhammad Ali Sahrayan. I'm a professor of neurology, MS fellowship at Tehran University of Medical Sciences. I'm head of the Department of Multiple Sclerosis at Sina Hospital and director of Multiple Sclerosis Research Center and vice chancellor for Iranian MS Society. Special thanks to you again and all the people, especially Sumaira. And actually, we are planning in Iran for the patients with MOGAD and NMO in order to be covered by the government and get the facilities of the patient with MS receiving that, because in Iran, the facilities are organized for patients with MS. We are actually registering them as MS NMO in order to be able to get the facilities from the government. And this is actually, I think we have to start a new foundation for MS, for MOGAD and NMO in order to put them as a disease like MS to be somehow approved for getting some facilities. Thank you very much all, and I can tell you that we see more and more cases of NMO and MOGAD during the last 5 years, especially during the last 2 years. We had much more cases of MOGAD. Unfortunately, we cannot do cell-based assay, and as Somaira said, Gila has been with Paddy, special thanks to him, and we are planning to have cell-based assay in Iran, hopefully near future. We have NMO clinic, a specialized NMO clinic on Saturdays in Sina Hospital. Dr. Zahra Ebadi and me, I myself, running the clinic. We have now registered 123 patients in our clinic, and we are following them. But the number of cases with MOGAD so far we have registered are around 30 patients. So I think this is not big numbers in Tehran, but in the whole country, we think that we will have around 1,000 patients with NMOSD.
Thank you. Thank you so much again. Paddy, do you have something to add?
Yeah, well, just thank you again for the invite. I think it's great. And it's great to have Professor Saharian leading this with yourself. I think it's very important to get MOG and ICOPORN-4 antibody testing, and it's a good idea to link them up with the MS for treatment. It's a very, very exciting time, and I think we're going to get a lot more diagnosis once we get this testing up and running. Thank you all.
Thank you. So thank you so much for all joining us today. So I will announce the next lecture session soon. I think we will have it like in March, hopefully. We will have like Nowruz, and we will try to find a day to join all of us from all different regions. But and also the lecture would be, I'm not sure at the moment, but we'll try to find a topic with Professor Saharian, and also we'll find a kind of a really nice lecture from the faculty of Somaira to have like a really nice talk for March, I hope.
Absolutely. We'd be delighted. And we're so happy that all of you came together. Thank you, Dr. MOGAD. Thank you, Dr. Muhammad Ali. Thank you, Sarah. Thank you, Dr. Samaneh. And let this be the beginning of many meetings to come. And whatever we can do as an organization, please let us know. Dr. Muhammad Ali, I hear you. I think we definitely need to do more on the advocacy side in Iran specific to these diseases, because we can't operate being in the shadows of MS anymore. These diseases are very much their own diseases that call for specific specialist treatments, guidelines, policies, etc. So let's definitely talk about what can we do together to help the Iranian community. But thank you all so much for the opportunity. I hope that at some point I get to meet many of you in person. But in the meantime, as a patient and as an advocate, I'm very, very grateful for any doctor, clinician, researcher who spends their time and energy on our diseases, because as you already know, we don't have enough people focused on our diseases. So very, very grateful, and thank you so much.
Thank you as well. Thank you for your energy. So thank you. Have a nice evening. Have a nice morning all together. So see you next time.
Thank you very much. Thank you so much.
Thank you. Bye.
Thank you. Bye-bye.